Okay, I think we're live. Hi, everybody. Welcome to our Friday live stream. I hope everybody's been doing well for the last couple of weeks. Today, we're going to talk about a subject that is near and dear to my heart, and probably yours too, if you've ever had such a thing as knee pain. And I'm actually going to talk about a specific kind of knee pain and go into some detail because it's one of the most common things that I see. We all know that you can have joint degeneration, you can have meniscus tears, but a lot of you might not know what's causing the front of the knee pain or anterior knee pain, the pain that's right underneath or right around your kneecap, which is also called your patella. So we're going to talk about what can cause that, what we can talk, we're going to show you, I'm going to show you a little bit more detail about what's happening with that, some pictures and some things that you can do about it. I'm going to talk about both surgical options and non-surgical options, which are my favorite. So let's get started. Sean is in studio with us today. He is not on his own microphone. He's going to share mine, but I had this was a little unexpected and I'm really happy about it. So we can actually take some questions. So for those of you who have some questions about our content today, please feel free to put them in the chat, and we will hopefully, if we have time at the end, we're going to take your questions and we're going to try to get them answered for you. So let's get started. So knee pain. Knee pain is such a common problem. And there's all kinds of knee pain and there's all kinds of reasons to have knee pain. One of the common knee pain problems that I see is something called patellofemoral syndrome or patellofemoral pain syndrome. And it is anterior knee pain. I'm going to show you a diagram here. I need to open something also. Let me show you this diagram though. So I have to open one other thing really quick. Sorry about that. So this over here is a knee. This is kind of the bony structure, and you've got the quadriceps tendon and the patellar ligament. There's other structures that are involved in this knee, but I wanted to show you this, especially the side view. So this is the kneecap, and this is your femur, which is your thigh bone, and this is your tibia, which is that shin bone and the main big bone that's in the lower part of the leg, and this is the knee joint. But the patella, so the patella has a joint also. Look at this. You have the patella or the kneecap here, and it rides very close to the femur underneath. The quadriceps tendon, so the quadriceps are those big thigh muscles. This is part of what keeps the kneecap in its proper position. Then you also have ligaments, so look at the ligament here. So when either one of these aren't doing their job, or they're pulling too much, or they're not keeping things stable, you can start developing this kneecap in some funky positions, and that can start causing problems. So if this starts to tilt down, it starts rubbing on the bone underneath. We know that bones rubbing on other bones doesn't end up with a good result. We end up with arthritis, we end up with degeneration of the cartilage, we end up with pain, we end up with spurs, and so that's not a desirable thing we want to have happening. So I wanted to show you that, and we're going to look at some more pictures here in a minute. So So surgical options for this problem when the patella is not in position. You can have a patellofemoral joint replacement, also called a partial knee replacement or a unicompartmental, these are all big words, knee replacement, but that means they're only looking at that section of the knee if the rest of the knee does not need to be replaced. So it's a surgical treatment option for individuals with arthritis of the knee that is confined to that patellofemoral compartment, which I'm going to show you again. This compartment right here, and not the entire knee joint. So that's a surgical option. Sometimes they put an implant around the bone there. It's not a super common surgery that I've seen, but it is a surgical option to have patellofemoral compartment by itself and not the rest of the knee. By the time the patient gets to the surgeon, a lot of times there's other areas of the knee that need to be helped as well, but that is an option surgically. Now, what about non-surgical options, which are my favorite? So I've mentioned this term regenerative medicine several times and on multiple different live streams. So what is regenerative medicine? Well, the main concept is to harness your own body's innate ability to heal itself, to restore damaged and painful structures like knees to their original non-injured state. So some of the tools that we use are prolotherapy, which is still in use today. It's one of the original regenerative options. And prolotherapy is basically where you take a needle and usually you're injecting some kind of a substance that doesn't have the same osmotic balance as the tissues around it. Well, I don't mean to get too technical on that, but usually a sugar solution is used. Sometimes it's a saline solution and sometimes there's a few other things that are added in, but it's usually a dextrose or sugar solution that's injected specifically at the target. Usually it's ligaments, sometimes it's tendons, where they attach to bone and other structures to get a healing response. And so prolotherapy is still used today. But since the advent of PRP or platelet-rich plasma, a lot of people are using, like myself, I do more PRP than prolotherapy because I'm often getting a very robust healing response with only one treatment, whereas prolotherapy really requires 4 to 6 treatments in the same area to get that response. But if you're someplace where you don't have access to a centrifuge or to the ability to concentrate PRP, prolotherapy is still a very successful, in some cases, procedure choice. Then we also have regenerative and stem cell isolates from your own blood. Those of you that know my practice know that I have a proprietary technique for doing that, and bone marrow aspirated cells. So, and you can also use peptides and others depending on the patient's needs. So there are a few other things that we can use, but I love combining peptides with regenerative procedures for these kinds of things. So again, these are non-surgical procedures that use your body's own ability to heal itself. I like adding peptides to enhance recovery of the knee, especially peptides like pentosan polysulfate, which is a small molecule peptide-like substance, and thymosin beta-4. And I will talk more about those in another live stream, and I've mentioned those before because they're some of my favorites. Pentosan polysulfate, just real quick, one of the things it does is it helps the body to restore articular or lining the joint cartilage. It slows the breakdown of cartilage and it gets rid of some of those toxic chemicals. It helps the body not make some of those toxic chemicals that affect the lining of the joint and induce pain and inflammation in the joint. So it's really nice to use pentosan polysulfate with a non-surgical regenerative procedure to get optimal results. And thymosin beta-4 is our healing peptide. Thymosin beta-4 is a bioidentical peptide. It's made in the body. And actually, we have a gene that is the thymosin beta-4 gene. So when at a moment of injury, that is one of the first genes that is turned on or upregulated and pouring out into the body thymosin beta-4 because it's such a recovery and repair substance. It goes to the area. It helps in many, many different mechanisms to heal. So one of the commonly asked questions that I get is, what about the older person who has long-standing degenerated knee problems? Or what if they've been told that the only option is knee replacement? Can a regenerative procedure solve those problems? Again, it depends. And you may need a knee replacement, but I encourage you to consider a regenerative option first. These regenerative procedures can still help a more chronic and degenerated knee to have less pain and longer function. I've seen it over and over in my practice. I have several patients that I can tell you about. One of them is Gerard. So Gerard had a very degenerated knee. He had not only patellofemoral syndrome, which he did, but he also had meniscus tears, he had spurs, he had very little joint space in his knee, and his knee was painful all the time. And he had been told by more than one orthopedic surgeon that his knee needed to be replaced. There was no other option. There was no clean out, there was no arthroscopic or small surgery to be done. It needed to be replaced. And he really wanted to avoid that for a lot of reasons. And so he came to me and we did a full regenerative procedure on the knee. And to this day, that was 5 years ago. And to this day, he is still able to function. He's able to work, like hard work and working on renovating a house, and his knee doesn't hurt him. And it still looks a little rough on imaging, but it's so much more stable now. There's no inflammation in the knee and there's no pain, and he's back to full function, including golf and other activities that he really enjoys doing. And I have multiple stories like that. But so it's always worth considering a regenerative option, and having, your images and having your knee examined, and to talk about it with, if you're anywhere close to us, come on in. I'd love to take a look at your knee and see if we can do something to help it. And if you're not in Florida, you're not, don't have the ability to come and see me, find a regenerative medicine doctor, have them do a full evaluation, because you just never know until you actually get examined and evaluated. So I wanted to show you some more pictures now of the knee. So here, now this is an MRI picture, and this is the kneecap, and this is the femur, or the big bone that sits underneath it. Just to orient you, femur, kneecap, this is the tibia. So we're looking at, this is a relatively normal knee. It was amazing when looking for images of normal knees. In my practice, we don't have any, because usually people are coming and getting an MRI of their knee because something's not right. So this is as close to normal as I've got for you, where so you can see it's like a puzzle piece. The patella is supposed to sit on top of the femur. There's a joint here. There's cartilage. This dark line is cartilage. And this is a relatively normal knee. This is a knee that looks different. You can see that the puzzle piece isn't quite fitting in there just right. You've got, it's kind of tilted. There's some fluid. This white is unwanted extra fluid in here. And so this is going to start causing a problem right here. It probably already has, where this is either in too close a contact, or we're creating a spur. So this one is even more dramatic. If you can't quite see that one, look at this one. So this is a severely tilted patella. It's not even remotely close to where it's supposed to be. So what are the options for trying to correct something like this, especially if there's still joint space here and it's not, just completely degenerated? How can we bring this patella back over and start to get it in a normalized position? Well, we talked about the surgical options, but let's talk about the non-surgical options. A lot of times there are specific exercises that can help this, but I will tell you that I really like the option of the exercises in addition to a regenerative procedure, because this ligament right here, if this tendon isn't doing its job and it's not strong, and this ligament is stretched or torn or not able to hold the patella in the position it's supposed to, these are great targets for regenerative medicine. So for PRP, or if there's a lot of serious tears or a lot of serious damage here, maybe a cellular option in addition to PRP. But a good PRP, platelet-rich plasma, can really shore up these ligaments and get these tendons much more functional again. So this tendon is attached to a big muscle. So I want to go back to, let's go back to this picture. So how do you think we'd be able to pull that tendon back over? In addition to giving the treatment, the regenerative treatment to the tendon and to the ligament, let's look at the muscles. I'm going to come back over here for a moment and bring my, here we go. Sorry about the delay. Okay, let me just bring you over here. Okay, so here, I'm going to show you, look at all the muscles. So you can see that if you have a patella that's being pulled too much this way, which would be laterally off to the side and not towards the middle, then maybe you need to work a little bit more on this aspect of the quadratus or the medial muscles. And There are some specific exercises that can do that, but the M-Sculpt, and I've talked about the M-Sculpt before, M-Sculpt uses high FEM, which is focused electromagnetic intensity energy that will actually cause development and contraction and build up the muscle fibers. And you can actually put the paddles on, I can't get it to come over here, but you see what I'm doing here, on these muscle groups and start really getting them stronger. And I've had excellent success in my clinic doing this, because sometimes, especially if the knee hurts, it's very hard to focus only on one of these muscle groups. But the M-Sculpt will actually focus for you. We put it right over the muscle group that needs to be strengthened to start participating in keeping that patella in its proper position. So M-Sculpt is another great resource. Now I wanted to show you again, there's some things that if you have patellofemoral syndrome and you have that anterior knee pain or the front of the knee underneath the kneecap or around the kneecap, these are some exercises that are not recommended until you get that patella so it's not, rubbing on the bone underneath and causing problems. You don't want to do deep squats. You want to really strengthen the muscles around that area. Lunges can be more painful for you, especially if the bone, when you're in that position and the bone is actually rubbing on the bone underneath it, that's not going to be great. And a leg extension machine. So using the machine can put too much force on that area or in the inappropriate part of the knee. You can do leg lifts and knee extension or leg extension exercises without weights or without a machine on the floor or on your own, just really focusing on strengthening and tensing up and contracting those thigh muscles. But it's not recommended to use a leg extension machine, especially if you're not being supervised. This is just an example. These are easily found exercises for patellofemoral syndrome. That's how you spell that on the internet. And these are, obviously here's a straight leg raise. You are putting the knee into extension, but you're using the weight of your own leg and not a machine. So there's all, and these are very standard. They're found, anywhere on the internet, and a physical therapist can do a very nice job for you of evaluating where you are with strength. And kind of walk you into it. And then these are exercises that you would be doing pretty regularly. So this is more our desirable position. This is not so desirable. So I hope that this has been helpful for you. If you're interested in the M-Sculpt, if you're interested in any of these, finding out how we might be able to help your knee or having an evaluation, go to drheather.net/contact and get in touch with us there. We are actually offering right now for this spring an orthopedic special, and we have 2 of them. If you're interested in finding out what that could entail, you just go to drheather.net/ortho-special and see if there's if you have a knee or if there's any other joint or your spine that you were hoping you could get better, especially with regenerative medicine. Please check out the special. It's a really great price reduction for a nice package of things to get you as well as we can get you, especially with a single treatment. And for more information about what, knee pain in general, you can go to drheather.net/knee pain. There's a video and there's kind of frequently asked questions, and you're welcome to check that out. Do we have any questions, by the way, Sean? Okay.
Yes, we do, Dr. Heather. Let's see. Linda asks, she says, what if I've had my knee problem for 20 years? Am I still eligible for an orthopedic procedure on my knee?
Hi, Linda. Yes, you probably are. Now you have to have to look at a lot of things, do a full evaluation. But yes, honestly, I have taken care of patients who've had long-standing knee pain for 20 years. 20 years is a long time, but there's still a lot that can be done. And I say that from the voice of experience. When I first started doing regenerative medicine, way back when in my fellowship, I would have not thought we could get such amazing results on joints that were, very degenerated or had been long-standing inflammatory pain. We also have other tools at our discretion, like the Shockwave machine. Shockwave is a high-powered sound wave that actually sends energy into bony structures or bone spurs and calcified structures and helps that energy helps dissipate some of those hard structures, whether it's calcification of a ligament or tendon, or it's actually a bone spur. So sometimes when there's been a long-standing issue and there's spurring, we can use shockwave to help reduce some of that spurring, and that helps you get an overall better result. So there's a few other tools at our disposal, and those are actually listed in the packages for those reasons if they're needed.
Dr. Heather, Lisa says, I'm 68 years old. Am I too old to have regenerative medicine?
No, ma'am. You are not too old to have regenerative medicine. I've treated people, obviously young people, but also people all the way up into their late 80s successfully with regenerative medicine. So don't ever think that you're too old. 68 is the new 48. So they say.
Bill says, I had a neighbor who had PRP done to their knee and it didn't help at all. Are all PRP procedures the same?
Thank you for asking that, Bill. No, they're not. Not only is the quality of the PRP or the concentration of the PRP potentially different from one clinic to another, the skill set is going to be a little bit different. You really want to be in the hands of somebody who this is what they do. They're very experienced at injection procedures using image guidance, whether it's fluoroscopy and or ultrasound, to be very image guided focused about where the injection is going. I know that there are some clinics that when they do PRP to a knee, they do not do outside of the knee. They only go inside the knee and put PRP only inside the joint. Well, as you can see from the diagram I showed you before, the ligaments and tendons, those are a huge part of stabilizing the knee so that we don't have ongoing instability and ongoing rubbing of structures that aren't supposed to be rubbing against each other, and just a much more stable knee. So when I treat a knee, or any joint for that matter, it's a more comprehensive process where we're putting some inside the joint to help quiet the inflammatory response that's happening in there. And then we start working outside the joint on all those individual little structures that each get their own little piece of the PRP or the stem cell preparation that we're using. So it's hard to know, and obviously if it was 100%, everybody would be all better. But we have pretty good success rates when, we will customize whatever procedure we're doing for the patient, for their condition, and for their treatment goals. So I would say I've had quite a few patients who've come to me who had some kind of PRP procedure done prior to coming here, and so they were a little bit not so excited, a little skeptical, but we've still had really good results. So it's certainly worth looking into. And where they went and who actually did the procedure. It's super, super variable. There's no standard in this section of healthcare right now. I hope that helps.
Okay, Dr. Heather, Bob asks, the stem cell procedures you do, are those embryonic stem cells?
No, sir. Embryonic stem cells are not used in clinical practice. What you may be referring to is amniotic instead of embryonic. Embryonic is actually human embryos, and that is not something that's used in widespread clinical practice for a lot of reasons, not just the ethical concerns. There is actually good science that supports that that's not the best choice for adult human tissues as well. But amniotic tissue or umbilical cord blood, that might be what you're referring to. That's a more common misunderstanding that those are stem cells that are being used, and actually they're growth factors. There are some living stem cells in those tissues before they are prepared for commercial use, and then they're irradiated and all of the cells are killed. So there's no living cells in those preps. It's a common misunderstanding. There's been some, partly because some of the marketing is a little confusing. It sounds like there's stem cells, and they're actually no living cells. Those are all growth factors, and they're tremendous growth factors. They can be a nice augmentation or assistance in a regenerative procedure, but it's not a cellular source. So I hope that clears that up for you.
Dr. Heather, you have a couple of peptide-related questions here, and that is your specialty. Peptology.com is where people can find more information about your peptide training. Stephen asks, do you use thymosin alpha-1 for regulating overactive immune system? My fear is that it would ramp up the immune system and make autoimmune condition alopecia worse.
Mm-hmm. That's an excellent question. No, thymosin alpha-1 does not just rev up an already dysregulated immune system. It actually helps to regulate a dysregulated immune system. So it is excellent for autoimmune conditions, because part of the problem with autoimmune is a very complex systematic problem that's going on with autoimmune. It's never just one thing, but it's a dysregulation of the immune system. And there's a lot of chemical signals that go on with that. And so thymosin alpha-1 is actually excellent for dysregulated immune conditions and autoimmune problems. So you're not going to have a worsening of autoimmune with thymosin alpha-1. That's just not been seen at all in any of the literature. It actually helps.
So we just have a couple more minutes here with Dr. Heather. If you have a question, just jot it in the chat, and I'm trying to get to as many as we can before Dr. Heather has to leave to see more patients and help more people. Lisa asks, she says, I've been doing a cycle of Pitocin for my knees. Is it typical for the solution to really sting when injected? She says, my doctor prescribed the Pitocin based on a video that you shared a few months ago, but she has not used it with any other clients, so she's not sure if that's normal.
That's a great question. Sometimes it stings. It usually doesn't sting if it's in the muscle. So part of the reason that we don't use Pitocin subcutaneously is it can be really uncomfortable if it's just, underneath the skin and not in the muscle. More commonly, the muscle is sore. Actually, it's kind of hit or miss. Some people will say one injection, their muscle was a little bit sore for maybe a day, and others will say the next injection, I didn't feel it at all. But if it's stinging, that might mean that you're not actually in the muscle. So stinging would be a sign that it's not actually seated in the muscle properly. And so sometimes you can look at injection technique. If the needle isn't going straight in at a 90-degree angle, you don't want to be on a curve like this. You want to make sure that you're actually in the muscle with your needle. So, but it is one of those substances that can be a little uncomfortable, not typically stinging. So I would definitely have your doctor look at your injection technique just to make sure that you're in the muscle and you're not on an angle, and everything is the way it's supposed to be. But it's not, like when you inject BPC or copper GHK, there's no uncomfortable, you never feel any discomfort. Pitocin, especially depending on the volume that you're injecting, it can be a little uncomfortable, but it shouldn't last either. It should kind of go away within a day or so.
And I should say that, Dr. Heather, you have a course, actually an online training course on injections. I think it's an injection and IV course. For more information about that, you can go to drheather.net/IV therapy. That's IV therapy, drheather.net/IV therapy. It's an online course for both patients and physicians, and it teaches you how to inject yourself subcutaneously as well as intramuscularly, and you also have some IV training. You want to just mention that a little bit, what that training's about?
Sure. So I developed this course to try to take all of the trial and error out of doing injections, both for yourself, and then if your staff hasn't really had much exposure to doing injections and you have members of your staff that are giving patients injection in the office, there's just a few tips and tricks that can make it go smoother and reduce the chance that the injection is either going to be painful or it's going to potentially be in the wrong place. There's a video series that I did. It's an online course though, so you can watch it from the comfort of your own home, about how to inject yourself for patients so they can learn how to draw the medicine up, how to make sure they're drawing up the right amount of medicine. We've seen that happen too. These are all common errors that happen with injection stuff, and how to make sure that everything stays clean, that there's no infections, there's no contamination, where are the best sites to actually do your own self-injections, and then how to start an IV. So it's IV placement technique, so that if you're not offering IV therapy in your practice, or your doctor isn't offering it and you would love to have IV therapy, it's a training video on how to place an IV catheter and all the tips and tricks that I've learned by placing thousands of them since I was in residency as an anesthesiologist and throughout my entire medical career. Placing an IV is something that you want to know those little things that could go wrong and how to make it a smooth process and the best for the patient as well. So I did a video series about that, and for physicians who maybe were like I was at one time, where you don't have anybody who could place an IV in you because you're the one who's placing the IVs, how to place an IV in yourself for doctors so they can get the benefits of IV therapy in their practice as well. But this injection series for patients is about how to do an intramuscular injection, also how to do a subcutaneous injection, but it goes from stem to stern on how to draw the medicine up, how, every little thing you would need to know about giving yourself an injection.
Okay, Dr. Heather, last question. Jen asks, I live in New Jersey. I'm told that I might need a knee replacement, but I'd like a second opinion. I know you're in Florida and I can fly to you, but do you work with patients outside of Florida?
Well, thank you for the question, Jen. I'm able to work with some patients outside the state and under some circumstances. Every state has its own rules about allowing a physician that doesn't have a license in their state. What kind of interaction you can have with the patient or with the citizen of that state. So we would probably just need to look at what New Jersey allows. There's a lot of states that allow 1 or 2 visits or some specialty care. So you would be able to come here to be able to do that. And then, of course, we would coordinate with the physician who's there, whether it's your primary care doctor or somebody to manage follow-ups and anything like that would need to be done. But contact the office and we can talk further about that because I'd love to see if I can help you.
Yeah, to start that conversation, you can simply go to drheather.net/new patient, drheather.net/new patient, and we can start that conversation with the staff here and find out what is required. Oh, a couple more questions are coming in here, Dr. Heather. Can you talk about the difference between Humanin and MOT-C, MOT-C, and how you use them with your patients?
Well, the MOTC is not available anymore, so I'm not using them in clinic. We lost a lot of our peptides when the FDA made their decision in May of 2020, and so I'm keeping in alignment with the FDA. So I'm not using those peptides anymore, unfortunately. I wish I was.
And quick follow-up from Lisa, who was asking about Pitocin. She says it's the solution itself that stings, not the injecting of the peptide.
Okay, then the solution may not be in the right place because stinging is not typical. So it might be for you. Maybe, everybody's a little bit different and I feel things that other people don't seem to feel when injecting certain substances. But I would just make sure that you're getting it in the muscle because stinging is more typical if it's subcutaneous, which is one of the reasons that we don't like to do it that way. So I would just look over your technique, make sure that you're getting into a muscle, maybe try a different muscle that might be less sensitive for you.
That's all the questions we have. Dr. Heather, I know you need to get moving on, so any final thoughts?
Well, thank you so much for joining today. I hope that this was beneficial and helpful, and certainly if you see yourself in this anterior patellofemoral knee pain situation, then I hope you can seek out treatment and that some of the things we talked about here will be helpful for you. Thank you. I'm always so honored that you come and join us for this time on Fridays, and I really, really appreciate it. I hope you have a fantastic weekend and following week, and we'll see you next time. Thank you again. Bye for now.